The gold standard approach for measuring the oxygen content of blood is to perform an arterial blood gas. Blood gas machines measure the partial pressure of dissolved oxygen in blood, and they always have done so. But these days, blood gas machines also accurately measure the saturation of hemoglobin with oxygen. Let's look at how these machines work. Fundamentals of anesthesiology and critical care with me, Pat Nelligan. Monitoring gases and vapors. Monitoring oxygen. Welcome back. In previous tutorials, we discussed the solubility of oxygen in blood and tissues and how oxygen is principally carried to the tissues by hemoglobin. The Oxyhemoglobin dissociation curve defines the relationship between the proportion of hemoglobin that's saturated with oxygen and the PaO2. And of course, that curve can shift to the left and the right depending on circumstances. Subsequently, we looked at pulse oximetry. But in the ICU and in the operating rooms, when we want to see what patient's true level of oxygenation is, we check a blood gas. And in this tutorial, I'm going to look at blood gas oxygen monitoring. There's two ways of doing this. The first is to measure the PaO2, and that's measured with the Clark electrode. And the second way is to measure the SO2 using oximetry. And I'll subsequently talk about Co-Oximetry and Methemoglobinemia. So let's start with blood gas oxygen monitoring. The first blood gas machines were built in the late 1950s by Severinghaus and Bradley, who combined a pH electrode with a novel CO2 electrode and a pre-existing O2 electrode to develop the three-electrode system that has been in blood gas machines since the beginning. So these are the early Severinghaus and radiometer machines. Of course, modern blood gas machines don't look anything like this. These are two modern blood gas machines. The radiometer machine, on the left, versions of which I've used for most of my career, and the GEM 5000 machine on the right. This is what we have in our ICU currently. Now, these are not simple devices. They are computers with fully functional laboratories inside, and there is an extraordinary amount of technology in them. The major technology in the GEM machine is that it contains a disposable cartridge that can hold up to 600 samples and has a shelf life of a month. And it reminds me a little bit of an inkjet cartridge or a series of inkjet cartridges that you put into your printer. The printer works away, printing away until either the cartridge needs to be replaced or maybe the cartridge head needs to be cleaned. And the major advantage for the laboratory of these devices is minimal maintenance. The lab techs don't have to come up several times a day and recalibrate the machines, and that's why they're very popular, and that's presumably why they have them in our hospital. Inside the machine is a complex system that measures all kinds of things. Standard blood gas measurements, pH, PCO2, PO2, and all the derived calculations, hemoglobin, glucose, lactate, sodium chloride, potassium, ionized calcium, and lactate. But what we're interested in this tutorial is the system that measures oxygen. The term amperometric sensor is used here. An amperometric sensor measures the electrical current produced by the chemical reaction at an electrode, and the size of the current is proportional to the amount of analyte, in this situation oxygen. And this is the sensor that's in the GEM 5000, but it's nearly identical to the original sensor that was developed by Leland Clark in the United States in 1953. And this is his original paper. And it's a seminal study that has assisted clinical medicine, without which blood gas machines would not exist. And it is one of the building blocks of modern critical care. And I think if you're someone who uses blood gas machines all the time, you really need to understand how the machine measures oxygen, and that's what we're going to look at for the next few minutes. Measuring the PO2 of a blood sample. Here is a representative cartoon of the oxygen electrode that is in all blood gas machines. First of all, we have a sample container. The sample container separates the blood sample from the electrodes by way of a membrane that is permeable to oxygen but not to proteins. Inside the apparatus, there is a bath of alkaline solution, usually potassium hydroxide. That separates the blood sample from the electrodes and bathes the electrodes. The system works by way of an electrical charge that always goes from positive, the cathode, to negative, the anode. The cathode is made of platinum, a chemically inert substance that is an excellent catalyst for oxygen reduction. A wire connects the cathode to the anode. The anode is made of silver and coated with a layer of silver chloride. A current generator passes a continuous current flow from the cathode to the anode of 0.6 volts. The anode is connected to another device, an ammeter or transimpedance amplifier circuit, that measures the electrical charge, the flow of electrons per second that is converted to volts, and the magnitude of that charge is the PaO2. Now let's see how this works in practice. When you inject a blood gas sample into the machine, some of it is diverted into a specific channel for measuring oxygen. So that blood sample enters the chamber where the apparatus is, and oxygen diffuses along the partial pressure gradient into the alkaline solution that bathes the electrodes. At the platinum cathode, oxygen is reduced. It takes in electrons supplied by the cathode to generate hydroxyl ions using water as the source. This generates current that passes from the cathode to the anode. The more oxygen that is present, the greater the current. The current is measured by the voltmeter, and following temperature compensation and using calibration curves, it is converted into PaO2 in millimeters of mercury or kilopascals. When the measurement has been completed, a flushing solution is applied into the sample container, and oxygen and junk products rapidly diffuse out from the alkaline bath along the partial pressure and concentration gradients, and the system is set up for the next sample. If you are asked in an exam what apparatus is used to measure PaO2 or PVO2 in a blood gas machine, the answer is the Clark electrode. It's the same technology as in that original machine. Now let's move on to talk about measuring the saturation of hemoglobin with oxygen in the blood sample. Most of the oxygen that is in blood is attached to hemoglobin, and the degree of saturation is the SA or SVO2. The SPO2 is measured by pulse oximeters. And so to determine the true oxygen content of blood, we need to know the hemoglobin concentration and what percentage of that hemoglobin is occupied by oxygen. Older blood gas machines do not measure SaO2. What you see on the printout is an estimate. So what the machine did is it measured hemoglobin, it measured the PaO2, and then it fed that into the oxyhemoglobin dissociation curve to give you the oxyhemoglobin saturation. Frankly, that is not good enough today. We need direct, precise measurement of SaO2, and that is achieved by a modern technology known as Co-Oximetry. Co-Oximetry is a laboratory technique used to measure concentrations of various different hemoglobin species in a blood sample by analyzing the absorption of light at multiple specific wavelengths. And the principal measurements by co-oximetry in our blood gas machines are oxyhemoglobin, deoxyhemoglobin, carboxyhemoglobin, and methemoglobin. The setup for co-oximetry is as follows. A specific quantity of the blood that's been injected into the machine is hemolyzed. That means that the hemoglobin is uniformly distributed in the sample, avoiding measurement error. A multi-wavelength LED light source delivers an array of light to the sample. A proportion of each wavelength is absorbed by the blood. Light that is not absorbed travels through to the photodetectors. Then the machine charts the wavelengths of light and is able to construct a table of different hemoglobin species. And you can see that the important species have different light absorption profiles. Although you might think that this is overkill in patients that you don't expect to have dishemoglobinemia, it provides us with a really good measurement of the true saturation profile of hemoglobin. This is the standard printout from the GEM 5000 blood gas analyzer. Let's zoom in on the co-oximetry values. A number of values are presented. The first is the O2 hemoglobin, and this is the absolute percentage of hemoglobin that is bound to oxygen, capable of carrying oxygen to the tissues. It's usually known by the moniker fractional hemoglobin. I'll get back to that in a minute. This is the carboxyhemoglobin, the percentage of hemoglobin to which carbon monoxide is bound, and by definition, unavailable to bind oxygen. This is the methemoglobin, the percentage of hemoglobin that is in the ferric rather than the ferrous state. There is usually a little, but it's clinically insignificant. This is the deoxyhemoglobin. And finally, this is the SO2, the functional hemoglobin, and that is the calculated saturation of hemoglobin that is capable of binding oxygen. In other words, if you look at the hemoglobin and you exclude all of the other abnormal hemoglobins, the hemoglobin that hasn't been interfered with, what percentage saturation you have. Let's explain that. So we start off with 100% of hemoglobin. In this scenario, the oxyhemoglobin, the fractional hemoglobin saturation is 92%. The deoxyhemoglobin is 5%. The carboxyhemoglobin is 2%. And the methemoglobin is 1%. Now we're going to eliminate the carboxy and the methemoglobin. And what we end up with is functional hemoglobin that we now have at 100%. And if we look at the oxy versus the deoxyhemoglobin, the functional saturation of oxyhemoglobin is now 94.5%, and the functional deoxyhemoglobin is 5.5%. So this patient likely has a small intrapulmonary shunt. On the blood gas, the SO2 refers to the functional oxyhemoglobin. The GEM 5000 and the radiometer ABL 90 use slightly different terminology to refer to the functional and fractional hemoglobins. On the GEM 5000, the O2HB is the fractional. On the radiometer, it's the FO2HB. Thankfully, on both machines, the SO2 refers to the functional hemoglobin. If you look at the printouts, the fractional hemoglobin is here, and the functional hemoglobin is here. They are not identical. The functional hemoglobin is by definition always higher than the fractional hemoglobin. So the fractional hemoglobin oxygen saturation is very useful in carbon monoxide poisoning or methemoglobinemia, as it provides us with an overall idea of how much hemoglobin is potentially available for oxygenation, particularly if the deoxyhemoglobin is high. Also, if you are trying to calculate the oxygen content of blood, you're going to use the fractional hemoglobin saturation. That's 1.34 times the hemoglobin times the fractional percent of hemoglobin plus 0.03 times the PaO2 in millimeters of mercury, or 0.225 times the PaO2 in kilopascals. So if you want to calculate out oxygen delivery and oxygen consumption, you must use the fractional hemoglobin saturation. The functional hemoglobin saturation is a calculated or derived variable that gives us an idea of how well saturated normal hemoglobin is. That's the relative percentage of oxy versus deoxyhemoglobin, and it's used to estimate intrapulmonary shunt. If the functional O2 saturation is normal, for example, in methemoglobinemia, there is no point giving the patient any more oxygen or increasing the PEEP. But if the patient has a low functional hemoglobin without carboxy or methemoglobinemia, then you can give the patient adjustments like prone positioning PEEP or more oxygen. How does the blood gas machine measure hemoglobin? If you look at the printout from the two machines that we've previously discussed, the radiometer and the GEM machine, the hemoglobin appears under Co-Oximetry. When whole blood is injected into a blood gas machine, it is split into two circuits. The first circuit takes that whole blood and analyzes the plasma, and from the plasma is derived the pH, the PaO2, the PCO2, and some electrolytes, sodium, potassium, chloride, and ionized calcium, and then it also measures lactate, glucose, and sometimes bilirubin. To perform co-oximetry, that sample needs to be broken down so that the hemoglobin is spread throughout the sample, because you're getting a grams per 100 mils measurement. And so a lysing solution is applied, and the lysed sample is then used to derive the hemoglobin and various different hemoglobin species by co-oximetry. In blood gas machines, a proportion of those red blood cells are lysed in the co-oximetry circuit. Free hemoglobin obeys the Beer-Lambert law. Multi-wavelength light absorption takes place, as we have seen, across 6 or 8 wavelengths. Oxy, deoxy, met, and carboxyhemoglobin is measured, i.e. all of the hemoglobin, and then the machine solves a simultaneous equation set to determine the absolute concentration of hemoglobin in grams per deciliter, and it is really accurate. Now, in our clinical practice, we send a complete or full blood count to the lab, but we also get a hemoglobin on our blood gas analysis. So the question is, what's the story? Which is more accurate? The lab lyses the red blood cell and then adds an enzyme to convert hemoglobin to only one absorbing species, so that's known as a chromophore. Then optical absorbance is measured. There's no co-oximetry, so you don't get all the different versions of hemoglobin. And there's a delay between sampling and measurement. You send the sample off, it goes to the lab, they eventually get to it, and then the result appears on the computer screen, or else a form is sent back. So it's not dynamic like blood gases where you get information within a couple of minutes. Usually venous blood is drawn and it can be diluted by IV fluid, although you don't see it very often. So the ABG or VBG hemoglobin is more comprehensive, it's more immediate, and likely more accurate than the lab version. So you can rely on this for hemoglobin measurements in the operating room or in the ICU. Let's look at a clinical scenario. A number of years ago, I was walking through one of our ICUs, and out of the corner of my eye, I saw an anomaly on a patient's monitor, so I went by to investigate. This was what was on the display, and the patient gave me permission to use it. You will immediately note the SpO2 is 80%. Surely this patient was in severe respiratory distress. But no. He was sitting in the bed, blue, typing away on his laptop, and we had a great chat. I looked at a blood gas that had been performed earlier, and you can see that the functional saturation was 99.9%. But the fractional oxyhemoglobin saturation was only 87.4%, and his methemoglobin was 11.9%. So this patient had methemoglobinemia. Methemoglobinemia is a disorder where the iron in hemoglobin is oxidized to the ferric Fe3+ state. That moiety cannot bind or release oxygen effectively. It manifests as cyanosis that does not respond to oxygen therapy, and the SpO2 is usually stuck in the mid-80s. When drawing a blood gas, the blood is typically chocolate brown in color. Now, for most patients who have methemoglobinemia, up to 20%, they are usually asymptomatic with mild slate-gray cyanosis. But over 20%, they start getting symptoms of dyspnea, headache, fatigue, dizziness, tachycardia, and then of course above 50% you're looking at full-blown hypoxemia, acidosis, arrhythmias, coma, death, etc. Now, our patient only had 12% methemoglobinemia, but you can imagine how much trouble such a patient would get into if they develop pneumonia, pulmonary edema, or pulmonary embolism. Let's look at the common causes of methemoglobinemia. The most common cause traditionally in clinical practice is local anesthetic, specifically benzocaine and prilocaine. Now, benzocaine is used topically. Prilocaine comes and goes as a popular local anesthetic. It was used for a long time as the agent of choice for intravenous regional anesthesia, for example, the Beer's block. But it's coming back into fashion. Dapsone is an antibiotic that is used for PJP pneumonitis. Nitrates like glycerol trinitrate, nitroglycerin, sodium nitroprusside, and amyl nitrate. Sulfonamides, Septrin and Bactrim. Then there is rasburicase, which is a recombinant urate oxidase. It's an antiuric acid agent used for tumor lysis syndrome, and ifosfamide, a chemotherapeutic agent. All of these agents produce oxidating metabolites or hydrogen peroxide, and the impact is greater in patients with glucose 6-phosphate dehydrogenase deficiency. This is glucose 6PD. That's an enzyme that protects erythrocytes from oxidative stress. It generates NADPH that keeps glutathione in the reduced form, and that neutralizes oxidative stress, preventing hemolysis. Here is a table of various causes of methemoglobinemia. Pause the video if you're interested. What about management for symptomatic disease? The first thing, stop the causative agent immediately. And then the agent of choice is methylene blue, 1 to 2 milligrams per kilo IV, and repeat as required at 30 or further minute intervals, maximum of 7 milligrams per kilo. Also give vitamin C, 2 grams intravenously. Consider exchange transfusion or hyperbaric oxygen therapy. Methylene blue is one of those agents you see around the hospital that's used in all kinds of situations, but it's a very specific treatment for methemoglobin. It's a chemical reducing agent that restores ferric iron to ferrous iron. That's Fe3+ to Fe2+, and it donates electrons to ferric iron, reducing it. That's all you need to know. So it basically takes Fe3+ and turns it in to Fe2+. So it reduces the ferric iron, and it works really well. It takes about 30 to 60 minutes to be effective. It's contraindicated in patients with glucose 6-phosphate dehydrogenase deficiency because they may not generate sufficient NADPH for reduction, and there is a risk of hemolytic anemia with high dose due to the oxidative stress on the red blood cells. An additional or alternative agent that you can use is IV vitamin C ascorbic acid. That directly donates electrons to methemoglobin, reducing the iron from the ferric to the ferrous state without requiring NADPH or the cytochrome B5 reductase system, but it's a much slower onset of action agent. So if you have a patient with methemoglobinemia, give them methylene blue first and then add vitamin C. Let's review this tutorial. In this tutorial, we looked at how oxygen is measured by a blood gas machine. We looked at how the Clark electrode measures the PaO2, and that can be the PaO2 or the PVO2. We then discussed how original blood gas machines just picked a SO2 off the oxyhemoglobin dissociation curve. But nowadays, Co-Oximetry is used to define the quantity of all hemoglobin species, and it gives us a very accurate value for oxyhemoglobin saturation. I finished with a brief discussion about methemoglobinemia. Next time, we're going to move on to looking at carbon dioxide. I'm going to explain what end-tidal CO2 is, and then we're going to look at capnometry, capnography, and examples of abnormal capnographs. I'll see you then, and I guarantee you'll learn something.